scenario is carcinoma of the gallbladder. The carcinoma of the gallbladder itself is a difficult case to treat by surgery, and associated with jaundice, which itself is not a very favorable factor for surgery. If we combine both of them, then it becomes even much more difficult. And what is exactly the scenario, in what percentage of cases this occurs, and how we can go about it? For that, I would like to invite Professor T.D. Yadav. He's a very, very eminent gastroenterologist in India, gastrosurgeon in India, and he's particularly in the hepatopancreaticobiliary field. He is from PGI Chandigarh, Professor of GI Surgery. Dr. T.D. Yadav will give us an overview of the role of surgery in cancer gallbladder along with jaundice. Dr. T.D. Yadav.
Thank you, Dr. Das. Very good afternoon to all. And thanks, Sir, Professor Kapoor and IASGO for giving me this opportunity. However, at the outset, I can say that CA gallbladder with obstructive jaundice is one of the most difficult thing in my career, which still today we don't know where we are and how to manage this patient. So I will give an overview. I prepared slide thinking that as Sir suggested that we are going to talk where audience is mostly students. So I tried to clarify many things, but I am hardly seeing any students, so I might go a little bit faster. So I have no conflict of interest, and these are the different people in PGI Chandigarh to whom we work with. These are our colleagues and medical and surgical gastroenterologist and radiologist. Dr. Santosh is sitting here, Dr. Hardeep was here. So what is the relevance of these statement publication is still today in 2020? Still, it means there is nothing is yet clear. Gallbladder cancer, many people say once you have a gallbladder cancer, stop there. With jaundice, I'm sorry, with jaundice, no treatment. And still many of our colleagues fight with us that why are you wasting the resource? And I also accept that till date in PGI, my career, we have wasted so much of resource, and outcome has not been proportionate to the resource wasted for the management of obstructive jaundice. In terms of outcome of resection, we do many things to palliate jaundice. So that's why these are very, very relevant things today for discussing all these points. So why it is important? First is most important is extent of the resection once gallbladder cancer is there in the presence of jaundice. Then what is the feasibility of that, what is required for the surgical oncology principle. And then we have two things in gallbladder cancer with obstructive jaundice. One is the disease itself. We have to take out the disease, but at the same time, the only organ where it is important that what organ you are living that can create complication and lead to the death. In other surgical complication can create, but here the organ which is being left over can create complication and then patient can die. So that is why it is very, very difficult, and then general condition of the patient. So these are the issues. So what are the causes, different causes of surgical obstructive jaundice? So can you remove this bar which is coming, Zoom bar? Zoom bar which is covering the slide. No, you can go to the side one. So what are the different causes of the jaundice? As we said, there are 4 or 5 important causes of gallbladder cancer presenting with the jaundice. Okay, you cannot do it, then leave it like this. Okay. So these are the sketches prepared by Dr. Santosh, who is sitting here. Now it is not working. So these are the most common causes in infiltrating time, where there is a mass lesion, maybe close to the body and the neck, and which is infiltrating type of disease. This is the most difficult to treat. Then another would be this. There is a mass lesion in the neck which is covering, and then different lymph nodes at different level, and then tumor itself. We talk in papillary type of tumor, where the tumor, they exfoliate and they go into common bile duct, and at different level, this can produce obstructive jaundice. So causes of obstructive jaundice, if you see, this is a mass in the leg, as I said, invasion at the hilum by the infiltrated type of the tumor, which is most difficult, lymph node compression, intraluminal tumor extension, and exfoliation, and extensive liver metastasis, which is the most least common cause. And if you see this particular sketch prepared by us, this is the area where we have the lesion, and this is the area where all the hilar anatomy is there. So that's why removing these tumors are very, very difficult. And this is our data of the patient of surgical obstructive jaundice. We have found the diffuse type is the commonest, followed by the neck mass lesion. So neck mass lesion is still better to treat in terms of this thing. And in most of the cases, the liver infiltration is about 98% in these cases, unlike when there is a tumor in the fundus or anywhere else and without jaundice. So before going into details, we have to understand why we need this type of resection planning. To planning the blood flow to the liver from the gallbladder bed is like this. So if you can divide gallbladder into two components, from fundus and body, it goes to right side, segment 5, and then for neck and this area, segment blood is flowing toward the left, meaning thereby when there is obstructive jaundice or lesion at the infundibulum and neck, it's not sufficient to only do a wedge resection. We have to do an anatomical resection, meaning thereby we have to come here. So I will tell why this picture is very, very important. So resection at least will involve going up to here and have a margin superiorly, meaning thereby segment 4B is must, segment 5 is must. These segments are must when you are doing a obstructive jaundice cases. So wedge resection is usually not adequate. So when a patient comes with surgical obstructive jaundice, what should be the ideal treatment based on what we discussed? So if this area, porta, is involved, so what is usually required is, if coming to this level, confluence is involved, then at least all this segment except 2 and 3 is left over. So that was what I was talking. And in a diseased liver, is it adequate? I will tell you that it's not adequate. So that's why it's more difficult. And segment 1 resection is also required when confluence is involved bilaterally. So this is very, very important to understand. And that's why gallbladder cancer with obstructive jaundice is very, very difficult. A modified approach that we follow we are saving the segment 4A, meaning thereby we are removing 5, 6, 7, 8, and trying to preserve the segment 4A, but B is resected, along with resection of the confluence, bile duct, and gallbladder. So this is what is to have an optimum volume of the liver. We try to do that. So this is the less preferred treatment, but technically very demanding, because vascular supply comes from left to the right, and sometimes it's very difficult to preserve the vascular supply of the segment 4. So you see this particular sketch which I prepared. So what I discussed, about 25 to 30% maximum liver is left over once we plan a really surgical oncology principle follow to resect a patient of gallbladder cancer with jaundice. So can we do this operation in a patient with a jaundice present at that time, a diseased liver? Is it possible? So the answer is big no, because the diseased liver is not optimum. At least we need 40% of the liver left over, a future liver and liver. Why? Because it's an injured liver, parenchyma resection need is very, very high, and there is a poorer functional of the liver volume which is left over. So even if you are leaving the volume of 30%, functionally we don't know whether it is adequate enough to for the patient to survive. And these are the different mechanism, but we have to understand that because of the cholestatic jaundice, there is a poor regeneration, there is a poor ischemia tolerance, and there is an increase of sepsis. And all the three are reasons for the post-operative hepatic failure, which is the commonest cause of death when you are going to that particular operation. So these are the different series where it has been described what is the extent. About 10 to 15% of the people will have, in spite of all the precaution taken, will have post-operative hepatic failure and death. So that's why it's very, very important to understand. So what are the strategies? So more important than only extent oncological, we have to prepare the strategy to prevent this 20 to about 15% death of the postoperative hepatic failure. So biliary drainage is most important, followed by, based on the liver volume future remnant, followed by portal immunization to enhance the liver, and then optimization of the future liver remnant by following these two. Then nutritional assessment, lots of discussion was done. These patients are usually anorexic. They have poor nutritional status and their immune capacity also decreases. That is very, very important. And then CT volumetry to have whether this particular liver which we are living is adequate or not, and CT is required for the roadmap. Then parenchyma preserving surgery, if we can do it, following the maintaining the principle of the oncology. And then, as I said, 40% remnant liver is required. But the 40% remnant liver also has a caveat that this liver, which are CT volumetry 40%, might not be 40%, parenchyma might not be functioning. So then, in spite of all, this leaves one gray area. So nutrition, as I said, these are people who are in suboptimal nutrition. I am not going to talk about this, but nutritional assessment, some particular criteria, following the criteria and preparing the patient before taking further surgery is the most important thing in any cholestatic jaundice. So now, what are the other challenges apart from future remnant? Complexity of the hilar anatomy. So if you see here, this is the bile duct, this is the right hepatic artery, right portal vein, and with all the anomalies present in this area. So that's why it becomes very, very complex. Then assessment of the tumor extent by doing MRCP, and then technical demands of the surgery, then achieving the R0 resection and liver resection with parenchyma preservation, which I said it is very technically demanded. And if there is a vascular involvement, do we need to resect? This is a question again. So these are the challenges in a gallbladder cancer. So surgical planning, certain things we do in the preoperative period, certain things we do in the postoperative period, apart from technical success. So in the preoperative period, as I said, preoperative nutritional support and preparing the patient by doing bringing down the jaundice. Then extent of the tumor by doing MRCP or PTBD gram or anything. Then vascular assessment, longitudinal spread by doing MRCP. Then vertical spread, portal vein, hepatic artery, and the liver, and metastasis, lymph nodal metastasis, and then FLR. So these are the three stages of preparing the patient. And future liver remnant, we have to do any type of biliary drainage, either endoscopic or perioperative biliary drainage. Without this, we cannot operate a gallbladder cancer with obstructive jaundice. Let's be very clear in the beginning. Most of the patients, some anecdotal patients, we can still do it. So perioperative biliary drainage, the commonest was PTBD. Still we are doing it, but there is a paradigm shift. In Japan, people are shifted from PTBD to endoscopic drainage. If there is a very aggressive and technically successful endoscopist or sarcophagus here, he might go, and even in a black duct confluence, you can enter the hilum. There are many reports, people do it, but most of the people are not able to do it. So still we are relying on PTBD, and it has its own complications. So that's any one of the both. So this is our patient where PTBD has been done. And after the PTBD, once bilirubin come below the 5, then you have to see go and do a portal vein embolization. This is a complication of the PTBD where you can still have a tract metastasis. So it has been described in the literature about close to 6%. There are some literature which suggests that there is no that much of theoretical risk is there, but not that significant. So that's why these things have been described. So as I said, portal vein embolization, there is a definite evidence that if you are embolizing the portal vein and selectively also embolizing the segment 4, there is evidence that if liver is working, parenchyma is good enough, then there will be regeneration. Here is a caveat that in spite of the bringing down bilirubin, and you are doing a portal vein embolization, and there is no increase in the FLR, then that is a marker that your hepatocyte parenchyma is not good, and it is not good for the resection. So this is very, very important. So portal vein embolization gives you 2 messages. One is that it gives you an indirect evidence that liver, which is cells which are functioning, are adequately functioning, and if it is not functioning, it is a contraindication to operate. So very, very important, this our patient, ALPS which has been described, you might think about, it is not recommended for the surgical obstructive jaundice. So after preparing, this is the summary of the set 2 minute I will take. Biliary drainage, nutritional optimization, portal vein embolization to increase the FLR, and correction of the coagulopathy, and patient should be free of the sepsis. So now what are the options available? So rarely we are able to achieve this. So I will just summarize that what are the options available. And this is our paper. You can go and see why we had such a difficult scenario in a PTBD management. And most of the patient, our patient, data of 60 patients where we could not achieve our what we wanted to achieve. So if you see, only one patient could be neoadjuvant therapy could be given. And only one patient we could operate in recent, about 2 years back, 60 patient data. And most of the complications were because of the PTBD related complication. Very rarely it was the tumor related metastasis and all those things. So we do a laparoscopy, we did a PET scan, and then just summary that after the laparoscopy, we go for a resection. So this is a patient where we modified now. If there is a blockage below the hilum and we can achieve the R0 margin, then here is the patient where we went ahead, did a segment 4B and 5 resection, common bile duct resection and hepatico-jejunostomy. Here is the patient where I said this is our patient with segment 4 parenchyma preserving precision after portal vein embolization. This patient after portal vein embolization, trisect could be done. So these are the options available. This patient was for the neoadjuvant therapy because of the nodal load, and still after endoscopy stenting, we could do a segment 4B and 5 resection with lymph nodal resection with hepatico-jejunostomy. So this is the summary. These are the different options available. You can do Taj Mahal, you can do segment 4B, you can do segment 4A preserving, and you can do a trisect. So these are the options available, and this is the summary of the option. And then coming to the conclusion, before going to this slide, I will just show the slide, Professor V.K. Kapoor sir, where jaundice in gallbladder cancer. This is yellow signal. The yellow signal means you are wait, you have to stop, wait, and then go. So it's not nihilistic that you cannot operate. Many of our friends still fight that we should not be wasting our resource. But you wait, and there would be some select group of patients who will still have a resection. So summary, this is summary from the meta-analysis, very recent. And summary is that optimal therapeutic strategy of jaundice patient. So slide is not coming. Sorry. Why? This is publication, search publication I was talking about, and I like this slide too much because you have to wait, and then he has his master of ideas. So he gave this very nice summary of the patient with jaundice, that every jaundice patient is not a red signal, it is a yellow signal, but it's not a green signal also. And this summarizes whole gallbladder cancer. So then this is the summary. The optimal particular slide let it. So what I said, this is the summary. Summary is that these patients are not clear-cut resectable, meaning thereby you have to do lots of effort. As I said, tumor along with the liver, along with the roadmap for the vascular anatomy, and then preparing the patient for the resection, where you should not have a future liver remnant inadequate, so that your patient should not go into liver failure. And then our resection after going for 2 segment resection has gone to 14%, and earlier it was in the tune of 7%. So that's why I said we have wasted resource. 2 publications, one from GV, one from the Tata, their resection rate is high. So I should compliment them. And thanks a lot for your kind attention. I can take any question later.
Thank you, Dr. TD. Before going to the panel discussion, I want to ask you one question related to that only. So what is the, for the students, what is the resectability rate, or what is the surgery? How many patients out of 10 or 100 patients of CAGB can go to surgery? And
CAGB after jaundice.
CAGB, only CAGB without jaundice.
Only CAGB, we are in the tune of 25 to 30%.
25 to 30%. And if it is associated with jaundice?
14% recently. We have reached to 14%.
And it has dropped down to 15%. So There are various, thank you. So there are various options, surgical options. Dr. TD has described that if we can do the surgery, we should do the surgery with a curative intent. And if there is jaundice, we try to optimize the patient, bringing down the jaundice to a certain level, below 3 ideally, and then go for a curative surgery of various types there that are available. But what about the rest 85% cases, rest 75% cases? Their number is not very less. So what will be happening to them? To discuss about that when we're not doing a surgery, we don't have a medicine. So obviously what is left behind is palliation. So for that palliation, to discuss about that, we have a esteemed panel with us. So I'd like to invite them. Next slide. Mirror slide. It's not it.
Slide.
Second slide. Second.
White क्यों कर रहे हैं?
Best slide white है sir.
सर मुझे चलेगा सर ये तो ये यहीं से बोलना
Yes, sir.
ये दोनों दिनेश नहीं है डॉक्टर श्याम सुंदर सर मास्क अच्छा ठीक है देखा सर.
So Dr. Dinesh was supposed to be here. He's not there. Then I would call upon. He's there. He's there. So sorry, I was told that you are not there. So Professor Dr. Dinesh Yadav, he is oncosurgeon from this medical college. Please come onto the dais. And Dr. S.S. Sharma, he has been here also. I saw his interactions. Professor of Gastroenterology from SNS Medical College and Hospital, Jaipur. Dr. Professor Neeraj Rastogi, please do come. He is Professor of Radiation Oncology from Sanjay Gandhi Postgraduate Institute of Medical College, Medical Sciences, Lucknow. Dr. Nikhil Bansal, he is Assistant Professor of Intervention Radiology from this medical college again. And Dr. Nipun Lamba, please do come, Assistant Professor Palliative Medicine from this medical college again, Jaipur. So I am at a distance from all of you. So, sir, my first interaction will be with Professor Dr. Dinesh Yadav, the oncosurgeon. So what will happen to this 75% of cases who are not being able to be operated? What is their fate? Yes.
Suppose CAG or other.
So we are discussing actually about malignant obstetric jaundice that has been told to be discussed. But let us focus on the CAGB part rather. That is, I consider as more important.
So first we have to decide whether these patients are for future surgery or not. Whether these are locally advanced. So if they are locally advanced, then we will plan for drainage of these patients. If they are metastatic or if we are not planning for any surgery, then we drainage is palliative drainage.
So if I say like this, that these people will have some symptoms which we need to palliate. Would you agree? Like, for example, they might have got jaundice. They might be having conditions, symptoms related to jaundice, like extensive pruritus, cholangitis, maybe bleeding. And they would be having pain, which is almost near 80% association with most of these patients. They can have obstruction at various levels of the bile duct as well as the duodenum, causing gastric outlet obstruction. In advanced stages, they can have ascites and ultimately going into the malignancy related terminal condition that would ultimately take their life. So what would be the lifespan of this patient so that we would think of palliation in these patients?
If we are expecting more than 3 months lifespan of these patients, then we will plan for palliation.
So, the point is the lifespan in these patients are very, very less, is in months, 3 to 6 months, you can say. But the quality of life is very, very poor because of these associated symptoms. Now, the commonest symptom needs to be palliated in these patients is pain, which is mostly associated with 85% of these people. How do we go about the pain in this people? Like, for example, if it is mild pain, if it is severe pain, my question is to the Dr. Lamba, of course, and why does that pain occur, and how do we go about it?
So cancer pain is multifactorial. The malignant pains will be there will be a neuropathic component as well as a nociceptive component included in it. And the pain is because of the subgastric distension and the tumor is involved in the science, multiple areas, it is metastasizing. So in this situation, sir, we deal with this pain using the Breslo's factor, which has given us guidelines for mild, moderate, and severe pain. Initially, we start with NSAIDs with or without adjuvants, and then in second stage, we add V-coplets like Prandol, etc. And if the pain is still not relieved, then we switch to stronger opioids. And since the cancer pain is multifactorial, so not only just the blood peptide, we have to take into consideration other aspects as well, like patient's nutritional status, his psychosocial history, his other problems the patient is facing. So when we lead the patient in a holistic approach, then only we can cure the pain of this patient. And apart from these medicines, when we are dealing with pain, we can also go for interventional pain management in these patients, like celiac plexus blocks, magnetic nerve blocks, IV lidocaine and ketamine infusions. They are our mainstay of treatment, and we are routinely doing these procedures in our institute also. We have a good experience with celiac plexus magnetic nerve blocks in the institute in cases of malignancy, the pain is not controlled by a virtual step ladder, then even if it is not controlled by morphine, then we are doing these procedures in this.
So this is true for the patients who are also having jaundice.
Yes, sir. Jaundice will be there. If it's a malignant obstruction, jaundice might be there. So we can do these procedures in time also. It will be very beneficial for relieving the.
So you start with one drug, or there is something that 2 or more drugs to be started at the same time,
Yes,
and you titrate.
Yes, sir. We start with the NSAIDs basically initially, and then we titrate the dosing according to the pain relief of the patient. And if the patient is not relieved, then we step up the ladder and we go to weaker and then stronger.
When do you decide for a celiac plexus block intervention?
So if pain is not relieved by morphine, despite of increasing doses, the patient can tolerate. Pain is not relieved, patient is having multiple episodes or spikes of pain during the day, despite of round the clock medication, like we give medication by the clock and by the letter. And still, if patient has persistent pain not relieved by continuous 4-hourly morphine and other neuropathic medicines, then we decide we should go for block. So in cases where patient present to us with severe pain and he might not be on WHO step ladder, and if pain is severe, then we might go for straight away celiac plexus block also.
So how long a celiac plexus block works?
So we are doing chemical analysis using alcohol. Its duration is usually 3 to 6 months, we say. And patients who are cancer, suffering from cancer, it's a reasonable time to achieve.
Do you add some anxiolytics?
Yes, sir, definitely. We have other supportive medications if patient is having other problems. We are dealing with.
And prescribing these medicines, can all of us prescribe, or like the hypnotics, opioids, or is it limited to only the oncologists?
Sir, actually, all the other medicines can be prescribed except stronger narcotics. For prescribing morphine, there are specific guidelines. There is a short-term courses are there of 15 days and 1 month. We require certification of them before prescribing morphine.
So Dr. Sharma is
others are also prescribing, but according to government guidelines, you need to have a certification proper before prescribing morphine particularly. Rest all medicines, everybody in prescription.
Sir, please.
So these patients of malignancy, whether it is a gallbladder malignancy or pancreatic malignancy, they may have pain due to other mechanisms also. In addition to the nerve involvement and neural infiltration, these patients may have pain because of ductal obstruction, ductal hypertension. Like CA pancreas may obstruct the pancreatic duct and cause pain, which is relieved by stenting of the pancreatic duct or surgery to stop the obstruction. So, similarly, the bile duct obstruction may also cause pain, and relief of the obstruction by stenting may relieve the pain. So, in addition to the neuropathic involvement or nerve involvement, there can be ductal obstruction, which may and ductal hypertension, which may be responsible for pain, and they are relieved by endoscopic interventions.
Yes, sir. So three types of pain, the mechanisms. One is a neurological one, neuritic pain, which you aptly said how to manage. Another is obstructive pain. So you have to relieve the obstruction. Another one, if I may add to that, is suppose associated empyema, associated stones in gallbladder. So Dr. Dinesh, would you like to do palliative surgery in these patients if you know that the patient is having empyema or stone, which can be the cause of pain, and whether we can really differentiate whether the patient is having pain because of the stones and empyema or is there neurite cancer pain per se? Would you like to go for palliative cholecystectomy in these patients who are suspected to have empyema or pain because of stone?
First, I will in favor of full palliation, pre-operative palliation. Not by surgical treatment, but endoscopic or maybe by guided palliation. Not by surgery.
Not palliative cholecystectomy. Sir, there is a old article from SGPGI that in advanced gallbladder cancer, if you do palliative cholecystectomy in these patients, the quality of life is better, and even they showed 2 months, 1 month lifespan increase in this patient. So that was a very old study. That's why I asked you about this, whether we should go about it or not. Sir, sir.
That was when you are not going through the tumor. So that was for patients who did not have jaundice. The tumor is in the fundus or body. There are metastases, and this is pre-PET scan, and before I think staging laparoscopy became a routine even with us. So it's a very biased retrospective analysis.
Yes.
That if you can do a cholecystectomy without going through tumor at any place, probably the chemotherapy will work better. So it may not stand to reason today, maybe.
Today.
It is very many years.
So, sir, today, should we go ahead with, if you have empyema, the patient is having pain? He said he won't go. But what is your opinion?
Not a panelist.
Sir.
No, because see, empyema means that probably the tumor is at the neck or cystic duct, it is causing clot. That is the reason why there is empyema. So cholecystectomy in that situation, you would either be leaving the tumor part behind and going through the body, where you run the risk of having a fistula, or you will go through the tumor. So
or a transhepatic percutaneous drainage.
Yeah, so what I'm saying that R2 surgery, gross residual disease surgery probably is not acceptable.
Yes.
So that's can I
Sir, please.
So I think it's what sir is saying. I will go one step beyond that. One is that first, if patient is having fever, we don't know whether it empyema is of such grade that then first of all, starting with the antibiotics, which are bile-concentrated antibiotics, and then proper hydration, and then trying to give a chance that if it is response, and then Dr. Dinesh said we can do either PTBD or PTC to relieve the jaundice. That is the first step. If in spite of that, you are thinking that we have 1 or 2 patients only till date, especially the patients who are standing have been done. These are the people, they are prone to have empyema because of some infection has been introduced. Here, going transhepatic, away from the tumor, to that by putting percutaneous drainage is probably much preferred method rather than trying anything surgical like R2 servicing, R2 resection. So I think we have to be very clear in the mind.
Yes. So that brings us to,
Sir.
yes, sorry.
Actually, one of the very good things in the pain palliation is the use of radiotherapy in these patients. Because the pain in the gallbladder is usually because of the infiltration of the liver capsule as well. The second thing will be in the retroperitoneal lymph nodes, especially paralytic lymph nodes, which are compressing on the lumbar nerves. These are the one of the commonest causes of the pain in the gallbladder.
Yes.
So if you give the radiation therapy to the gallbladder area, including the liver and also including the paralytic lymph nodes. So, and 70% of the cases you will get the pain palliation. So, and this pain palliation usually for a duration of 3 months, and it can also decrease the use of the narcotic drugs like morphine subsequently.
So when do you decide to give radiotherapy in these patients?
Actually, initial, Dr. Lamba has told that initial part is definitely you can use the medications like
NSAID.
and narcotics, and subsequently you cannot able to achieve that, especially the retroperitoneal lymph node, which is sitting on the lymph node, lying on the lumbar.
Around the bile duct.
These can really be by the radiation therapy.
And what is the standard dose?
Those usually in the palliative dose, depending on the, we have too many palliative fractionation, like 20 grain, 5 fractions. And you can give the 8 grain to single fraction, various fractionation schedule is available, 30 grain, 10 fractions.
So we'll again come back to you, sir, in that aspect. Now, the second thing is jaundice. So if the patient has jaundice, could be mild, moderate, or severe, and he comes to us with, let's see that, let's imagine that he doesn't have any medical risk factor or something. He is eligible for all types of treatment we are giving. So mild jaundice, moderate jaundice, and severe jaundice. So what should be the approach for us? Sir, Dr. Sharma, please.
Any patients with gallbladder or palliative malignancy who comes with jaundice without cholangitis, without significant pruritus, and if there is no expected delay in the surgery, and these patients with mild jaundice, they can be subjected to surgery if there are no contraindications and the patient is surgically fit. So for mild jaundice, there is no need of palliation. For some, it depends upon the preference of the operating surgeon. Many of the surgeons here, they say that we will not operate when the looking is 50. They will be comfortable if it is less than 6 or 7 or 5. So they will be comfortable. They would request for the surgeon themselves request us to do palliative drainage. Otherwise, surgery in these patients can be taken if there is no cholangitis or significant problems.
So we're speaking of palliation. We're speaking of palliation now, not optimization. So we are palliating this patient. Of course, the chance of having mild jaundice in this advanced disease is less. So let's think that they have high jaundice, maybe above 10, like that. So when do you decide to palliate this jaundice?
Well, if we talk about palliation, we consider 2 groups of the patients. One is the lower CVD block, lower block causing obstruction, and one is the hilar block. There are mainly 2 groups. So patients with lower CVD block, they are very safe for any stenting or any endoscopic procedure. So we would even do palliation in these patients if they are not surgically operable with stenting. But for the hilar block, the problem is that type 1 and type 2 blocks, we can easily go with endoscopic palliation. But type 3 and type 4 blocks, they pose a significant risk of cholangitis if we try to relieve the jaundice without significant indications. These patients must have some cholangitis in the form of fever or leukocytosis. They must have significant pruritus. Otherwise, if you try to palliate without expertise, these patients may end up in trouble with shortening of the lifespan. So those who are dealing in the type 3 and type 4 blocks, they must have sufficient expertise in endoscopy, plus they must have facilities for percutaneous drainage. Because in case some of the patients endoscopic drainage alone is not sufficient, additional PTBD is required. So higher blocks, they should be carefully taken, while lower CBD blocks can be easily handled with the help of stents by the endoscopy.
So we'll discuss about that hilar blocks. So first, if we are thinking of this lower end blocks, then I think endoscopic treatment is good, but any contraindication, any situation where you really can't do endoscopic palliation of lower end block.
There are certain situations where we are helpless endoscopically. When the patient has got D1, D2 obstruction, we are not able to go beyond the obstruction. We are not able to reach ampulla. Or extensive infiltration of the ampulla by the tumor or within by tumor, we are not able to cannulate. Otherwise, hardly there is a situation where we are not able to do ERCP in these patients.
Or there is a gastric outlet obstruction.
Yes, D1, D2 obstruction or gastric outlet obstruction.
And you would stent them with what type of stent?
The patient has got an expected life expectancy more than 3 months. We would prefer a metallic stent. Otherwise, we will put plastic stent. So life expectancy is more than 3 months. Ideally, metallic stent should be used. They have got longer patency and less reintervention.
So life expectancy of these periampullary people with metastasis is little bit more than the carcinoma of the gallbladder because of various reasons. So if you think it is 3 to 6 months, plastic or metallic straightway.
If it is more than 3 months, I prefer metallic stent. But a patient is not affording or patient, then we can put a 10 stent or bilateral stent.
So they are costly, the metallic stents. So for higher blocks, because of the tumor at the neck of the gallbladder or at the hilum, the hilar cholangiocarcinomas, or lymph nodes blocking at any higher level, so we need to palliate them. You said that you can still try endoscopic treatment, and stenting, if it is possible, should be done. But I think if there is a problem, suppose you could cannulate, but you are unable to stent, then you are introducing infection to the. No?
We ideally do in these patients. Before doing any endoscopic procedure, we always ask for a MRCP. By that, we can assess that how is the chances of success of the endoscopic procedure. If endoscopically this on MRCP, if we see multiple intrahepatic segmental strictures, we don't try ERCP in these patients. But if the patient has got just separation of the conference with good dilatation of both the ducts, we can pass the new guidewire across both the sides, and we can put the metallic stent on both the sides if it is required, depending upon the volume of the liver which is functional. Ideally, the basic principle is you should drain at least 50% volume of the liver to be helping in relieving the jaundice and pruritus. Some people say 35%, but it depends on the functional status of the liver. If liver functional status is okay, 35% drainage is okay. If liver functional status is poor, at least 50% drainage should be done.
Say 1 or 2 lines about the endoscopic ultrasound, which is now coming up in the palliation of the jaundice. What is your opinion?
Yes. As far as the drainage is concerned, if suppose we are not able to drain with the ERCP, then second modality of choice is endoscopic ultrasound guided drainage. People have compared PTBD with the endoscopic ultrasound drainage, and now more and more favor is going towards the endoscopic ultrasound drainage because of less complications, less reinterventions, and less time consumption.
So what do we exactly do in endoscopic ultrasound drainage?
In endoscopic ultrasound drainage, depending upon the accessibility of the scope into the duodenum, if scope we are able to go into the duodenum, we and the block is disturbed, we can do EUS guided bilateral duodenal drainage, ESBD. Or if we are not able to go into the duodenum, then we can do left hepatic duct, left hepatic bile duct and gastric drainage. hepaticogastroscopy.
So if we are unable to do the palliation from below, then we have the choice to approach that one from above.
Yes.
And that's the job of the intervention radiologist. I will come to
Endoscopy ultrasound guided is job of gastroenterologist.
no, sir. If you are going from above, means from the liver side, you can go by endoscopic ultrasound. If these two things are not possible, then we go to intervention radiologist. So, Dr. Nikhil Bansal, please. So, what is your opinion about the palliation of jaundice, the role of intervention radiology in the palliation of jaundice? I'm not taking into granted that endoscopy is the best form of palliation. So what is your opinion?
So we usually prefer the highlight blocks. Usually the duodenal blocks or can be well taken with the endoscopy.
First, you agree that from below, if there is a blockade, then endoscopic is the best.
Endoscopy is the preferable choice. If
Yes.
it's straight, then we can go ahead with the PTB drainage.
Yes.
In case of a highlight block or a separate system, I prefer the PTBD as a better role. If the patient is having clinical symptoms, then only we usually prefer the biliary drainage. Otherwise, in the patient, like if the patient is planning, if the surgeon is planning for the any surgery or patient is planned for a chemotherapy, then the bilirubin usually preference is less than 5. In those cases, we also do the PTBD.
So the PTBD is putting a catheter percutaneously into the hepatic parenchyma, then approaching into the duct.
Yes, we usually prefer the peripheral IHBR. Yes.
So what is the success rate of PTBD? Is it 100%?
If the system, if the IHBR is more than 2 mm, I think with the good experience, more than 98% or 96% is there. If the system is non-dilated, like less than a mm, the success rate is somewhere come down to 90%.
So you are putting tube on one side and there is a hilar block. How do you think that it will decompress both the sides?
To the cholangiogram, if the system is separate, then we have to do the PTBD from both the sides, from the left and right.
So there are studies unilateral versus bilateral. People, the studies say that even if you do a unilateral, also you can decompress, you can manage the case and relieve the cholangitis and jaundice to a significant extent. You agree?
Goal is to drain somewhere around 70% of the total body.
And it is said that post-operatively or post-procedural complications of PTBD are very high. And what are they and how do we manage them?
There are two ways of puncturing the gut. One is a ultrasound guided puncture and second is a blind puncture. So if the person is using a good ultrasound machine, I think the complication rate is very less. If we are going ahead with the blind technique, then the chances of bleed or counter puncture through of the portal vein through the hepatic vein, hepatic duct is there. In those cases, the chances of bleed is there, sir. If we are only puncturing the parenchyma and coming into the hepatic duct, like IHBR, then the chances of bleed remains very less, sir.
Okay, and you will do PTBD, then what? The patient remains with the tube lifelong?
So, sir, if the patient is ready for the stenting, then we can go ahead with the internalization. And stenting can be done either with the plastic stent or with the metal stent. It depends upon the survival duration of the patient, expected life of the patient. As sir said, if it is more than 3 months, then the preferable choice is metal. Or the patient is non-affordable, or the lifespan is less than 3 months, then we go ahead with the plastic one.
So we should stent them if it is 3 to 6 months, more than 3 months of life is left. So you should stent them preferably with a self-expandable metallic stent.
In a patient like those who are not agreed with the or not affordable with the for the stent, then we can use the internal external catheter, in which we park the catheter as a multiple hole, which is the distal end is parked into the duodenum and the whole extend till the hepatic duct.
So when we do stenting in these patients, there is we are not treating the disease itself, the tumor grows. and there is a chance that it would also ingrow into the stent and block further. To stop that or to tackle that, Professor Neeraj Rastogi, would you suggest something?
I think once the stent is made, usually what we do, the intraluminal biliary radiation, what we do. Usually it is done through the percutaneous biliary drainage. The percutaneous biliary drainage, we have a route to introduce our radiation source into that. So usually the time of the stent, because the frequently the self-expanding metallic stent is also blocked due to tumor ingrowth or tumor overgrowth. Or sometimes it is due to the lymph node which is compressing along the CB. So what we do, we put the intraluminal radiation therapy tube into the PTBD tube, and after putting the PTBD tube, we pass the radiation source there. And after passing the radiation source, it gives a single day radiation, usually to the 10 gray, which is giving radiation 1 centimeter on either side. Basically, it's a 2 centimeter diameter area is treated. So it can decrease the tumor regrowth as well as tumor overgrowth. So it increases the stent patency for a longer time, as well as if the stent is patent for longer time, then probably the overall survival, which is usually be 8 to 10 months.
Thank you very much. And that brings me to the last question to Professor Dinesh. Any role of surgery in palliation of jaundice nowadays, present scenario?
So routinely we go with the surgical palliation, surgical palliation always better than standing. But the patient is not fit for surgical palliation. Second thing, life survival of these patients are not advanced. Only rare cases we go with surgery.
So if we go for, if we are going doing a laparotomy, patient is not stented, we find dissemination. So do we do a surgical palliation or we close and go for endoscopy later?
The patient is not jaundice, by reference to those and the COVID palliation.
Okay, thank you very much. Thank you very much, sir. So I'll call him after thanking the panelists.
Regarding what I like to add, there is
Yes.
a new technique called radiofrequency ablation of the nerves, and if survival is more, then instead of seeing plexus, we prefer radiofrequency ablation of spinal nerves. It provides much more relief, even lasting 2 years, in cases of intracerebral abdominal pain or pancreatitis or jaundice. We can use that every time. That's it.
Okay, thank you. I now invite Dr. Anand Mohan to interact with the audience with his questions and give a take-home message with summary of that to be handed over to Professor Kapoor. Thank you, please.
I would like to thank VK Kapoor sir for the opportunity given. So I think most of the questions have already been discussed in the panel. So I would like to ask, sir, is there any role of neoadjuvant chemotherapy in resectable gallbladder cancers with obstructive jaundice?
There is a definite role, and we are very sincerely following that. And last patient, if you see my third patient, I took one patient for each type of scenario. And if you saw my last patient, we did because of the lymph nodal disease. So as a protocol, first we do a biliary drainage. Then after we have assessed patient, then we try to do a staging laparoscopy, but sometimes logistics are not possible, then we don't do. And then we start chemotherapy. We are practicing GEMOX. And then we see the response. So it is very important today that surgical obstructive jaundice patients are locally advanced, and we should try to introduce more and more chemotherapy. And we have been able to operate more patients. Maybe after 2-3 years, we find more and more resectability in this.
So even TMH data, sir, was
Yeah.
talking about paper, more R0 resections if NSCT was given to patients who had surgical jaundice with resectable gallbladder cancers. So, sir, I would like to ask regarding the role of radiation in palliation for pain in HPV oncology. Is there any contraindication, or if a patient, any long-term side effects, GI toxicity, when we give higher fraction single dose? Now I was reading somewhere 25 fraction single fraction is also feasible for pain neurolysis.
Actually, most of the time, but we give the 20 grade 5 fractions. Usually they have those 1 fractions. The only problem with the toxicity is the duodenal ulceration and gastroenteritis is the problem. But usually it appears usually in 6 months or later. So most of the time, these patient doesn't survive for a longer time. So our aim is to palliation of the pain rather than the life expectancy. So we have to increase the quality of life because patient is pain free for that period of time. And usually the side effects of radiation therapy most of the time is not seen.
So even GI hemorrhage, duodenal ulcerations and all with 25 fractions over 5 days is okay.
Small intestine can able to tolerate up to the dose of 50 grade. And if we take the 20 grade 5 fraction, it's somewhere equivalent to that dose. So usually it takes a long-term dose.
And regarding any contraindications for celiac neurolysis percutaneously or RFA ablation when we are considering pain palliation for patients?
Contraindication is only there is a local site impact.
Local site or spinal deformities or something.
Deformities are always there. It depends on cervical expertise that we are, we can do it. As if there is no contraindication, I feel except local site impact or the if pain is not really you have to do it, sir. There are multiple techniques of celiac also. If it is not chemical neurolysis, then we can go for anesthetics that will last for the time. Or we can go for other conditions. So we can do the same procedure by alternative means if there is any.
So practically no contraindication apart from local.
US guided celiac neurolysis.
That is also
India compared to the other methods of neurolysis. I think any more and more popularity.
so that can be done at the time of biliary drainage, sir, if I can ask. No, if like duodenal gastric outlet option, we are planning US guided drainage of biliary system.
As many patients as you want, patient is allowed.
Okay. And I think when to choose ERCP and PTBD has already been discussed in a lot. Thank you, sir. For this. So I think it was more or less discussed. People predominantly these have obstructive jaundice during the palliation only. They spend a lot of time, and there are very few patients who can get palliative chemotherapy, and as such, there is not much role as of now.
So, sir, for neoadjuvant chemotherapy, what is your expected?
So ideally, like many of the surgeons prefer bilirubin less than 3 sometimes when they are doing a major hepatectomies. And neoadjuvant, it depends, some 3 or 5, and even Lalit sir spoke that he is comfortable giving, after stenting, he is comfortable in a jaundice patient also giving chemotherapy.
Routinely forward, it's a 3 and.
Routinely it is 3. But Lalit sir in the.
As a chemotherapy also poses.
But Dr. Lalit interestingly said he is comfortable giving once it is drained.
Gemcitabine where best chemotherapy must safer. Gemcitabine in a central obstructive jaundice is much safer, everything much safer in comparison to that. However, everybody wants at a level of 5-star to do that.
Thank you. Thank you, panelists. Thank you, Dr. Das, Anand. So that brings us to the end of the PG course. I would request Dr. Dulundu, the IASCO president, if he would like to say something before we close.
Thank you very much. I have to say that I tried to participate all these 2 days to all the session, and I have to say that I really impressed by the speakers and discussions, and I'm sure that all the participants, it was very fruitful for them. And I would like to congratulate my friend Professor Kapoor and the organizing committee for organizing such a kind of high scientific level organization. And I would like to thanks to you for your kind hospitality and warm relationships. Thank you. Thank you very much. Thank you.
So once again, I would like to thank IASCO for allowing us to hold this course. I would like to formally thank my institution for providing all the support. I would like to thank all the faculty from outside Jaipur, from within Jaipur, and from within our institution for accepting our invitation and coming. All of them came on their own costs with no burden on us. So thank you very much. Some of you may be a little disappointed by the number of delegates who are present on site or online, but I belong to a different school of thought. I believe in the Dronacharya theory. Dronacharya had just 5 students, out of which also I think 4 were not interested in learning much. Only 1 was interested. So that is good enough. As long as you have even 1 student who is interested in learning, a good teacher should be ready and willing to teach. So going by that philosophy, I think all your efforts have been successful because at least some students were there. And I think the trend of teaching is changing from classroom teaching or textbook teaching to online teaching. And as I was sending a message in between, that more than the number of students who were present here or who was present live on Zoom were the views of the YouTube, which my team in Ahmedabad, which is supported by one of my former fellows, Dr. Avinash Tank, immediately after the session is over, they are posting the video on the YouTube. So the first session yesterday, I just got a message, has already got more than 125 views. So I think that is what the trend of teaching is. And probably we will have to rethink as to how teaching should evolve from classroom to maybe online. So with that, once again, and I don't think I have to thank my colleagues in the department, my faculty colleagues and residents, because they are part of the organizing team. So thank you very much. And with that, we come to the end. Anand, Vinay, you want to say anything? Good. So we all have a small group photograph again here, and then we go for lunch. Thank you very much. And all the online participants, thank you very much. If you can, join us for lunch online. Thank you.